Hi, everyone. My name is Luca Pisterzi, and I'm the Vice President of Research at the Alzheimer Society of Canada and moderator for today's conversation. It's my pleasure to welcome you to this installment of our Dementia Talks Canada series titled, Let's Talk About the Many Faces of Dementia in Canada. As many of you may already know, our new report that came out on January 22nd is called The Many Faces of Dementia in Canada, and today's talk provides a chance to hear directly from key people involved about that report, what it means, and how it was developed. This talk is presented by the Alzheimer Society of Canada in partnership with Brain Canada. You can find out more about both organizations in the chat. Before I jump into welcoming our panelists, we need to go over a few housekeeping items. This session is being offered in English and in French. To select the language, you can click on the interpretation button at the bottom of your screen and then choose the language you want. You will also notice that poll questions will occasionally pop up on the screen throughout the session. The poll answers help us understand the poll answers help us understand. Sorry, lost my place here. Whether we're meeting your needs, so please do provide feedback. My apologies for that. This talk is being recorded and will be made available on the Alzheimer Society website and the YouTube channel early next week if you want to revisit or share it with friends. Lastly, this is a conversation. The chat is open and being moderated for conversation should you wish to introduce yourself or share resources and experience. If you have questions for our panel, please send them through the Q&A feature on Zoom. We'll do our best to get questions answered, and any that aren't answered during the hour together will be followed up via email in the days to come. So please do provide your name with your question if you would like a follow-up and we don't get the chance to address it. I'm coming to you today from the land that is traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nation, Inuit, and Métis people. I also acknowledge that Toronto, where I live and work, is covered by Treaty 13 with the Mississaugas of the Credit. The Alzheimer Society of Canada encourages you to learn more about Indigenous-led and co-led initiatives in dementia, including, but not limited to, the Native Women's Association of Canada Dementia Resources, the Anishinaabe Dementia Care website, the Canadian Indigenous Cognitive Assessment website, and tools that the National Collaborating Centre for Indigenous Health reports, just to name a few. The websites of these organizations are now in our Zoom chat for you to use, share, support, and learn from. And now it's my pleasure to introduce our speakers who will be joining us on this conversation today, both of whom provide important perspective and insight. First, Joshua J. Armstrong is a research scientist at the Alzheimer Society of Canada and author of the report, The Many Faces of Dementia in Canada. He also authored a report we released in 2022 called Navigating the Path Forward for Dementia in Canada. Josh brings research expertise in the health sciences, data analytics, gerontology, and public health to the Alzheimer Society of Canada. Welcome to today's talk, Josh.
Thanks, Luca.
Thank you. Next up, Natasha Jacobs is an advisory group and referral service manager at the Alzheimer Society of Canada, and she helped bring the many faces of many of the personal stories shared in this report to the publication. She also has family experience with dementia. Her grandfather developed dementia at age 62 and went on to study gerontology and work in the dementia field as a result. Welcome, Natasha.
Hi, everyone. Thank you.
So we'll start off today's presentation with Josh leading that. So Josh, over to you.
Thanks, Luca. I'm happy to share some of just an overview of the report today. So if I could please have my slide deck, that'd be great. Yeah, I'm just going to briefly go through some of the results that you can find in the report. So next slide, please. We know for a long time that with the aging of the Canadian population, that we expect the numbers of people living with dementia to rise fairly dramatically as those baby boomers get into their 70s and 80s. So with the Landmark study report, we wanted to update, use the most recent data to try to understand what to expect for the Canadian population from the years 2020 to 2050. From the Landmark study, we have 3 reports coming out. 2 you can already find on our website. So that's first, Navigating the Path Forward for Dementia in Canada, where we focus on primarily on the numbers, the projections. We also look at the potential impact for prevention activities. But today we'll mostly be focusing on the Many Faces of Dementia in Canada, where we try to put a face to those numbers and share some stories. And we hope to follow this up with a report on the economics of dementia care in Canada, where we layer on top some dollar figures to these projections that you can find within the reports. Next slide. Nope. It's just a little bit of brief methodology around what the Landmark study is. It's a model, a microsimulation model that was developed by our partners, the Canadian Centre for Economic Analysis, or CanCEA. They used 2016 census data from the Canadian government to recreate the Canadian population, and we can use that as a basis to try to understand how that population is going to change going forward. But on top of that, we layered data from dementia risk factors from across the Canadian population. So as the simulation occurs, each of the individual agents within the model has a risk of developing dementia. We can use this approach to really look at what to expect in the population, and we can compare across sex, across ethnicity, across provinces, all while accounting for population dynamics, including immigration, death, etc. So if we look at some of the results from the first report, if we follow the current trends that are currently existing, we would expect to see over 6.3 million people developing dementia over the next 3 decades. So that's what you see in the figure on the right-hand side. The dark blue bars is that increasing number of people living with dementia, all the way up to over 1.7 million by the year 2050. The light blue bars at the bottom are what we call incidence numbers. So the number of new dementia diagnoses that we expect to see over the time. And you can see by the 2040s, those numbers are getting fairly high, where we expect almost 21,000 new diagnoses each month. So with these growing numbers, this led us to the second report, the Many Faces of Dementia in Canada. With these growing number of people that we expect to be living with dementia in Canada, I think now is an important time to really get a better understanding of the diversity that's found amongst people living with dementia in the country. So we use the second report to really take a look at these many faces of dementia in Canada and try to highlight this diversity that's found within those who are experiencing dementia. We do this by not just sharing a breakdown of the numbers from the first report, but also by sharing stories from individuals across the country. So here you can see an example from the first chapter, Rubina, who shared her story. So we can really put a personalized, we want to put a face to the numbers. It's easy to kind of just get lost in statistics if we're just talking about millions here, hundreds of thousands here. We really want to recognize that each one of these numbers is an individual who's deeply impacted by this condition. There are 4 main topics in the report. I'll go through each one of them very briefly. We won't highlight too many. I won't get into too many details, but I'll just try to highlight some of the findings and kind of give a brief overview of each of the topics. Start with dementia and Indigenous peoples in Canada, followed by differences across ethnicity and race. The third topic is looking at differences between sexes and genders. And we follow that up with a chapter on young onset dementia and some of the distinct challenges that they face. So we'll start with chapter 2, the dementia and Indigenous peoples in Canada, where we focus on a range of different topics. When we look at the data that we used to build the model, the 2016 census, over 2.1 million people reported Indigenous ancestry within that data. So we use that to build the model, and we understand that when we look across Canada, there are a large number of communities and a large number of languages spoken, a lot of diversity within the Indigenous population. Often we break this population down into 3 main groups: First Nations, Métis, and Inuit. And when we look at these populations, they're often considered to be youthful, young, but also it's important to recognize that Indigenous populations are also aging just like the general Canadian population. Here at the bottom of this slide, I share some of the statistics where we expect to see a growth in those people living over the age of 65. And it's important with age as the most important risk factor. When you have a growing number of people over the age of 65, you expect also an increasing number of people living with dementia within the Indigenous populations of Canada. But it's important not to just stop there at age. There are other important factors when it comes to health outcomes in Indigenous populations. We focus a little bit on the social determinants of dementia, and we use this model on the right, this tree model, to try to emphasize this deep web of connections when it comes to the health outcomes in Indigenous populations. And it emphasizes the connection all the way from colonialism and how that impacts not only just the systems that influence health, but also those individual factors that we often focus on in public health, those health activities We need to kind of broaden our focus and think about these web of connections and how a range of different factors can influence health, not only just in Indigenous populations, but across all populations within Canada. Within the chapter, we also focus on how stress can affect brain health, chronic stress from things like daily exposures to racism, poor housing, underemployment or unemployment. This kind of stress can influence the brain negatively, and over time, we're now starting to see how research indicates that in late life, this can lead to challenges in brain health and worse cognitive outcomes and higher rates of dementia. We also highlight studies that show that racism can be a barrier to healthcare and how that also impacts dementia care access as well. We also emphasize that future research on dementia in Indigenous communities must be Indigenous centered and Indigenous led. We highlight, use a figure to also demonstrate the need to break the cycle of racism in healthcare and how racism can impact a range of things and how it's important to try to address that across the country. At the end of the chapter, we highlight some of the available Indigenous dementia resources that have been created through funding from like the Public Health Agency of Canada, among others. So just to share some numbers that come from that landmark study model, we look at just Indigenous populations, we expect a 273% growth in numbers from 2020 to 2050. So that's almost a quadrupling of the numbers based on the data that we have. You see on the right what that growth kind of looks like over the years. But again, we don't want to just focus on the numbers. We also share stories of people of Inuit, Métis, and First Nation descent. So you can see some of those faces at the bottom of the slide there. The next chapter focuses on ethnic and racial diversity of people affected by dementia in Canada, looking at some of the variation that exists across different communities. When we look at Canada, we know that it's a very multicultural country. That 2016 census that forms the basis of the model, over 250 different ethnic origins were recorded. This diversity is now considered a fundamental aspect of the Canadian population, and this is largely a result of several waves of immigration over the past 50 years. When we think about the population being diverse, we also are growing recognition of that our older adults are also becoming more varied in terms of where they come from. And this also will be seen with those people who are living with dementia. They are also diverse, and also this is changing over the generations. Why do differences in dementia rates exist across ethnic and racial groups? It's a good question. Research from both the UK and the US have consistently found that there are differences across different ethnicities. But much more work is needed done to determine why this exactly might occur. Some of the reasons that are suggested are that there are potential disparities in rates of dementia risk factors. We know that conditions like diabetes, heart disease impact some ethnicities more than others. So that might be driving some of these differences in risks that we see. We also need to discuss the social determinants of health and how they can negatively or positively affect brain health in racial and ethnic communities. So I think that's important to look at more closely. We can also consider differences in genetic risk factors and biomarkers across the different groups and how there are differences known, but much more work is needed to be done to try to better understand how this plays out in terms of health outcomes in late life. People from racialized communities can also receive poor quality dementia care, and this can influence some of these outcomes. And I think it's widely recognized that when we look at dementia research overall, a lot of diversity is actually missing. A lot of the work hasn't been done in populations that are representative of the Canadian population. So work has been done, it's underway. More work will be done to try to address the fact that this is occurring. One of the key findings from this report is that when we look at the dementia population at 2020 and 2050, we see a pretty big change in it. If you just hit the forward key, you'll see the highlight where we see the largest growth is in people of Asian descent, so that's East Asian and South Asian. In 2020, they made up 7.8% of people living with dementia. By 2050, that percentage, that piece of the pie, grows to 24.2%. So by 2050, almost 1 in 4 people living with dementia in Canada will be of Asian origin. It's not because Asians are at greater risk, it's because of the demographic of that population. They're much more older adults who are of Asian descent. And this is what we see driving up these numbers. In fact, if you look at the data, Asians are actually at lower risk than other groups. So it's not risk, it's the demographic makeup of the population. And as it's changed in Canada, it's going to be changing in people living with dementia as well. Of course, don't want to just focus on numbers. We also share stories here. Just a brief snap of Arlene's story, Ama's story, and Navjot's story, who shared details of their experiences with dementia within the report. The next topic is looking at sex and gender differences in dementia. And I think there's many distinctions in dementia that matter when it comes to both sex and gender. When we look at the data across many different high-income countries, females tend to outnumber males in dementia diagnosis at approximately a rate of 2 to 1. So for every 3 people living with dementia, 2 of them are females. When we look at why this might be, I think we need to consider both factors related to the sex and gender of a person, because these will influence dementia experience all the way from before symptoms start in terms of risk through to treatment and beyond. In the box on the right, I highlight some of the differences that you can see in terms of sex and gender that might influence risk of developing dementia later in life. Why do these differences occur when it comes to dementia rates? I mentioned in the last slide that for every 3 individuals with dementia, almost 2 are female. Often this is attributed to differences in longevity or life expectancy. In Canada, for example, women tend to live about on average 4 years longer than men. With age as the strongest risk factor for dementia, this can drive a lot of why we see these differences in numbers. However, I think there's much more to the story to the sex differences than in just lifespan. If you look at data from the UK, the US, and you control for these differences in longevity, some places there are no differences in risk between males and females. In other places, females are still at higher risk. What this tells me that this is complex and depends on where you live, your biology, and also social factors as well. Here at the bottom of the slide, I just highlight a few of the different sex-related factors that can influence dementia risk later in life. But we also need to think about gender too, and we can think about risk and how it relates to gender in different ways. It comes across the lifespan through things like education and career complexity. And it's important to recognize too that these are very much what we could be considered cohort effects. So these will change over time. Experiences of my grandparents won't be the same experiences across the life course that my parents will have or that I will have. So it's important to recognize that. It's also recognized within the report that people's identities can often be consumed by dementia diagnosis. We often don't think about gender and sex when it comes to older adults living with dementia, and I think it's important to recognize those individuals for their own personal characteristics. When we're thinking about challenges that people experience when providing care or even when living with dementia, women and men have unique challenges that we shouldn't take this one-size-fits-all approach. And more research is really needed on the experiences of non-binary, intersex, and gender diverse people in Canada and beyond. On the right-hand side in the box, we highlight how dementia characteristics or the clinical presentation of dementia can also be known to differ across sex and gender. It can have an influence on the rate of progression, it can have change in it can have an influence on the changes that people experience in their mood, personality, and behavior. Even responses to treatment might vary between the sexes and genders. And when it comes to diagnosis, there are also important factors that have been recognized that can influence that part of the process as well. When we look at some of the results, here you can see the growth in dementia over time, and the yellow bars being females and the orange bars being males. And you can see that if the current trends prevail, there'll be steady growth over that time period. And the numbers to look at that people seem to focus on is that by 2050, over 1 million females living in Canada will have dementia or the symptoms of dementia. Chapter 5, when we look at young onset dementia and some of the distinct challenges that they face. The term young onset dementia refers to people that develop symptoms prior to the age of 65. It's a relatively new term. We use it instead of early onset dementia to try to avoid any confusion with early stages of the condition. The term's not new, but the phenomenon itself of developing dementia prior to the age of 65 is not new. In fact, if we actually look at the history of dementia and Alzheimer's disease, the original first two patients of Dr. Alois Alzheimer, where they connected these changes in the brain with changes in cognition and behavior, were of people in their 50s. There's Auguste, who you see on the screen here, and Johann F. So it's not a new phenomenon. This has been going on for quite some time. We have this new term, and I think it's more research needs to be done to try to better understand the range of different causes of young onset dementia. When we focus on young onset dementia, I know there's challenges for dementia. People live with dementia at any age, but when you develop it at a younger age, it prevents a number of overlapping unique challenges due to the time in the life course where they get impacted. When we look at people under the age of 65 who develop these symptoms, often have a wide range of symptoms and a wide range of known causes for those symptoms. There's also tends to be a lack of awareness among healthcare workers about the existence of young onset dementia. And these issues can combine and lead to a delay in diagnosis, which can lead to challenges for the individual and their family. You can also have interrupted careers, challenges with taking care of young ones, and even a challenge getting workplace accommodations to address the development of young onset dementia when you're still in the middle of working in your position. When it comes to the numbers, you can see on the chart on the left that we do expect growth from 2020 to 2050. The growth isn't as extreme because it's not driven by the aging of the population, but it's driven just by the growth of the population and what we expect to see during that time period. We should recognize, though, that more recent research is actually starting to demonstrate that the rates of young onset dementia actually might be higher than what we expected due to this challenge with trying to get diagnosis under the age of 65. And again, don't want to just focus on the numbers, but here we share more faces of dementia, more stories and experiences with the condition here with young onset dementia. So those are the four main topics, but I want to highlight the fact that diversity in dementia doesn't just stop when we talk about indigeneity, sex, ethnicity, and age. There are more characteristics to consider when we're thinking about diversity in dementia. This could be things like sexual orientation and dementia risk, and dementia care and dementia support. We also can think about the dementia experiences of people with intellectual and developmental disabilities, some of the challenges that they face in terms of assessment and of recognizing the condition as it develops as individuals get older. We also can consider dementia experiences for people who are incarcerated and how we need to kind of work on developing our response for when people do develop symptoms when in prison. Furthermore, we can think about homelessness, substance abuse, many different factors to consider when we're thinking about diversity in dementia, characteristics that are important in terms of outcomes and care. I think it's important that we recognize that we are all unique, but our shared characteristics and differences are important to recognize when planning future supports. At the end of the report, we do have a list of recommendations from different lenses. So you can please go to that report and try to see what we are suggesting as best ways to kind of move forward and improve dementia care in Canada. Here you can see some recommendations, but I want to just wrap it up and give time for my colleagues to also speak. Thank you very much for listening. And again, focusing on the people experiencing, I think, is an important aspect of all things that we do when it comes to dementia care and dementia support. Thank you.
Thank you, Josh, for shedding some light on these rather alarming trends. I really appreciate that. And you touched upon how important the stories were in terms of really helping us understand the impact of what these trends mean. I'd like to turn over to my colleague, Natasha. Natasha, some key differences from the last landmark study and this one are the stories told and the images shared. Can you tell us a little bit about this?
Hi, everyone. Thanks, Luca, for the introduction. Yeah, I would love to discuss the stories and images that are shared. It was sort of my absolute pleasure to be able to speak to some of these people about their stories. Their stories were really real life stories of love, of immigration, of resilience, of perseverance, but also some barriers to some of the care that they were able to access. Arlene shared her story of her father, of his diagnosis journey. And one of the things that she spoke about was that as his symptoms progressed, he reverted to Tagalog a lot. And having someone who was there to speak his language and to explain the diagnosis to him and what he may begin to experience, what their family could understand was coming down for them, and how to properly care for him would have been a huge help to them. Her family is one that everyone sort of comes and takes turns taking care of everyone. They talked a lot about just challenges in communicating with him. And so those were some real um, key points for us to take back. It's not even just about the landmark study, but there was a lot of learnings during this when we were speaking to the story sharers about some of the things that we can improve as we go forward. Next slide. And again, I had the absolute pleasure to speak with Heather, who shared her story of her and Kurt. Theirs is one of a real love story. They talked about traveling. They talked about her children. And one of the differences here was that she's also so young. And some of the story about Kurt was more that he was a young man experiencing some anxieties, and some of the symptoms that he was shown weren't taken seriously because of his age. And of course, she thought because of his race. So a lot of things around aggression came up. He was then at one point put on some antipsychotics. It is a very tumultuous story, but also one that she, really fought for him and fought for his care and fought to get the right diagnosis. And one of the things that she shared is that when she was looking for support, being in support groups, she didn't relate to anyone in the support groups because they were always kind of an older support group, and that there wasn't one that was tailored to her age. Or when she was looking online, she didn't really see herself in the stories. So the reason she even came to Alzheimer Society of Canada was to be that face that people were sort of that people could look for, that she was hoping to see when she was looking for support. So again, just a really rich story, really awesome connection for us. She's part of some work that we're doing right now within the diagnosis, like some of the work that we're doing to improve diagnoses. So she's really sort of jumped in 2 feet first. So really appreciate her very much. And the next slide. And Andrea shared her story as well with us about her family and her children, her younger children who also had a hard time relating to anyone. They would be in their sort of teenage years and young 20s, and were looking to speak to others in their kind of cohort and couldn't find anyone that they could relate to. She also spoke about when she would go to her doctor's appointments or physician appointments, that people would often refer to her partner as her sister, or not allow her partner in the room at all when they were talking about her care or about her diagnosis. And this was something that she really is very passionate about. She is an artist. So again, when you're looking through the stories that she shared, also look her up online because her art is there, and she shares even her story through her art. So lots of different angles that she spoke about in her story, and just a really beautiful way of allowing us to find ways to care for her better, and to make recommendations to physicians and to those who we work with, to understand her partner and what they've been going through, and how we could make positive changes in that space. And that's
Thank you, Natasha. That's great. Among the many recommendations in the study include actively engaging a wider range of ethnicities and racialized population in research studies, and to engage impacted communities as co-designers of research, examining the overlap of race, gender, and other characteristics in the dementia experience. In your opinion, Natasha, how can we begin to do this in our work?
Yeah. I think that also one of the things that we got when we were speaking to people was that they are part of their community. So they're part of churches and they're part of community centers and they're really involved in areas. And instead of, for instance, them finding us, it would have been nice if we sort of found them. So one of the things that I really found was that, maybe we take a step back and look into what spaces we could go and find folks where they are to talk about some of these differences. So I think examining how we've worked in the past, examining how we partner with everybody from very diverse backgrounds is really learning exactly what they're involved in and becoming involved in that as well. Welcoming them into the research that we're doing, and really sort of marketing it as a way to invite them to be partners with us long term, so that any research we do, any programs that we're doing, really reflect the journeys that they're on.
Mhm. Great, thank you. Josh, how about you? Why do you think it's important to recognize diversity in dementia?
I think with the growing number of people living with dementia, it's important to recognize that there are different needs and different understandings of dementia across the country. So a one size fits all approach doesn't work. We need to take a approach where we design our supports and our services to meet the needs of the people that are experiencing the condition. So in order to do that, we need to understand who's developing dementia, what their needs are. So that's where understanding that diversity aspect and trying to meet people with where their needs are, I think is important. We can only do that by understanding that in the first place.
That's great, thank you. I think it's also important to, at some level, build capacity and research these communities. So work with the researchers that know these communities quite well to empower them to lead research studies, and more importantly, to co-design those research studies. So that's fantastic. And rings quite true. So before we head over to our audience questions, I'd like to invite Natasha to take a minute or two to share a personal story about her journey with dementia and her family experiences. Would you mind, Natasha, sharing a little bit about how this report shares and aligns with your experience?
Sure. My grandfather was diagnosed with, back in the day, we'd say early onset Alzheimer's, but young onset dementia really probably is what it was. Um, he started showing signs around 62, 63 years old while he was still working. So driving to work, sort of in and out of the house and showing different symptoms like rewriting his name. When the adults would be in one room, he was kind of with us children a little bit more. Things that I was sort of 9 years old, 10 years old, so I didn't quite understand and probably wasn't out of the ordinary even for others until now. You kind of look back and think about. And from that perspective of a young child, I think that when I think of our story, it was a story of our family coming together and rallying around my grandmother, but one where my grandmother didn't talk about his dementia a lot, one where we as a family didn't really sit around and talk about it a whole lot in a way that was, what's next? How do we look for help? That sort of, that I can remember, at least, let's say that. And I think that when people are searching for accommodations, searching for help, they are looking for somewhat of their story to sort of be shared. And I think when I think about this landmark study and I see the pictures and the stories told, it could be a starting point for a conversation for a lot of families. It could be something that they do take to their physician and say, hey, the Alzheimer Society came out with this study and it talks about my community, and I am seeing some differences in my father, and I want to make sure that we are being thoughtful and that we are coming out and saying we need help at an early stage. I think by the time my grandmother asked for help or really admitted that something was wrong, there was more physical things that were happening with my grandfather, and it was almost too late. She really could have accessed care at a much earlier stage, and really her health might have benefited if she wasn't just trying to look after him on her own, sort of in the night. A lot of times we worried about him, falling down the stairs behind her or those type of things. Um, And again, I think if there was somewhere that she was in the community and someone was talking about it, maybe she would have related to it. So there's a lot of learnings that I think we could take away from this study that can help others begin the conversations at home from this study. Yeah.
Yeah, and I can't think of any more important perspective to include across all the work we do than the work you lead with persons with lived experience. It really needs to be our North Star in terms of helping us guide and shape what we do, what we have done, what we will continue to do at the Alzheimer Society of Canada. So
Absolutely.
thank you for that, and thank you for the work you do, and thank you, Josh, for the work you led on this report. So we'll turn over to any questions we have in the audience here. And please, as was noted earlier, if you could type them into the Q&A box within Zoom so that it may be easier to access and find. I don't see any questions at the moment. Let's see here. So a question from Ngozi. Does ASC plan to do more research within these populations moving forward? Josh, Natasha, any comments?
Oh, we would for certainly hope so. Like I was mentioning earlier, how this idea of understanding population better and their needs and how we can best support them. I think we don't really know much about that now. So I think it's important to do that research. So whether it's us doing it or us supporting it or somehow working with others, external agencies to try to better understand differences across the population and how we can best support them. It's obviously a goal of all of ours to optimize supports for people living with dementia. So yes, hopefully we can do that. And with your help, Ngozi, too, it would be great.
Absolutely. And also, if I could offer my position here at the Alzheimer Society of Canada is to coordinate those opportunities within ASC. So if anyone wants to be a part of our research, wants to be a part of any of the programs and projects that we are doing, they would contact me and I would set them up with any opportunities throughout ASC that we have going on. I also offer a monthly newsletter to let you know about all the opportunities that we have here. So you could just sort of email me and say, yep, I'd love to be a part of that. And then off you go. So we do invite anyone to be a part of any of the things that we are doing. But yes, a lot of the research that we will be doing is within certain sectors and different populations. And so when that does happen, we will put a call out to specifically partner in those different areas.
And if I can add kind of a bit to that, I think it's not so much to just go out there and expect people from these different underrepresented communities. They've been traditionally underrepresented in research. I think the underpinnings of that is trust. So it is paramount for us to rebuild trust with these communities. And first and foremost, listen. Listen to some of the challenges they're having. Listen to some of the questions that are of importance to them, and begin to really work on that co-design process. So that's something that I think is really essential to really help include groups that would like to be included and haven't been in the past. Okay, so I'll stop talking. We have some more questions here. Fantastic. What is the research on various faiths?
I don't know much. I haven't dug into it very much when it comes to differences across different faiths. The data wasn't available within the Alzheimer study to look at that. We didn't have that kind of data collected within the study. But yeah, I don't know if people have actually even focused in on that, but it's definitely an important thing that we could consider and look at. And not only just in terms of are there differences in who develops dementia across different faiths, but how these different faiths choose to support their loved ones when they do develop dementia, and how can those individuals be supported in the work that they do. So lots to do there still. Lots of work to be done.
Thank you. Next question is, autoimmune vagus nerve seem to be attached to dementia. Please comment.
I can't comment on that too specifically off the top of my head, but anything that really has a negative impact on the brain as you get older can lead to this vulnerability to developing impairments in cognition and changes in behavior. So we don't fully understand all the mechanisms behind what develops dementia, but we do know that there are all these range of different risk factors that can lead to increased risk or increased chances of developing the condition. Age being the strongest risk factor, but if we look at other risk factors, some could be sex and genetics, but there are a range of modifiable risk factors, things that we can do to work on to address that risk. So these go from lifestyle characteristics that we always talk about, exercising and eating well. We could also think about sleep, not smoking, reducing your drinking, really working with your physician to improve your overall health. It's going to have an impact to improve your brain health and thereby reduce your dementia risks. So I think trying to be as healthy as possible, it's going to help your brain, and it's going to help you, even your risk of developing dementia, or if you have dementia, you're still doing those things to improve your health, you might have better health outcomes if your overall body is and brain is healthy. So I think lots of things we can work on in terms of trying to address the risk in the population. Lots of different theories for why dementia might develop in an individual, and more work needs to be done to figure that out. Yes, hope that helps.
Yeah, no, that's great. And it's important to note a lot of the prevention strategies and things that can be implemented cut across several different areas. You know, there's a lot of common risk factors that cut across dementia, cancer, and other conditions. So you're kind of doing many things at once. But yes, it's a great comment. Thank you. And next, are there any events happening throughout the year to bring general public awareness about dementia?
We don't have any, I think, lined up quite yet. I'm sure we will try to build that out as we go. I do have some invitations to some local societies in Ontario, but I'm sure we'll do more work, but that also across the entire Alzheimer Society Federation, work will be done to raise awareness about this report and issues coming out that are coming out from the Alzheimer study work in general.
Right. Next question is, do you have suggestions for a family situation where the spouse is unwilling to accept support for their husband or wife who has dementia, and creating a scenario where now you have two people who are having declining health?
Sorry, the wife is, could you repeat that, Luca, for me,
Yes.
please?
Any suggestions for a situation where the spouse is unwilling to accept support for their husband or wife who has dementia, husband or wife who has dementia? And so you have two people who, so this is a kind of a caregiver situation where one is acting as the informal caregiver for the other, and by informal I mean paid versus unpaid, so like a family caregiver. And now you have two individuals whose health is declining. So any comment on?
Sure. I think my advice and really my key thought is, without knowing the individual, is that sometimes a little more education on what supports are out there for the family. A lot of times stigma around what will happen when you sort of finally admit that this is what's going on. A lot of people think then the next move is long-term care. It doesn't always have to be that. It might feel like they are going to have to lose some independence. So a lot of times, and I know this sounds dangerous, but a lot of caregivers won't talk about their spouse's dementia because it means then he has to stop or she has to stop driving, and that's their independence. There's a lot of little situations that might come up as to why somebody won't seek help. But understanding the transitions, understanding what comes next, really having a real deep conversation with their physician or with even their local society, it may not be as scary as they probably think it is. And I think, again, it's just sort of an education, maybe a moment to talk a little bit more to the caregiver about their situation. They can call our sort of our phone line if they'd like, just to talk anonymously to somebody about it, or they could call their local society to just have a conversation, sort of bridge that gap of unknowing and knowing, to start the conversation about how to get that care going. I think sometimes is key.
Right. Thank you. Next question is, doing research with communities requires a culture shift in terms of how research is conducted. What can research funding bodies do to facilitate this culture shift in the research world? And maybe I may ask Inbal to elaborate a little bit about what you mean by culture shift, if that's possible. You can do so in the chat or... Now, any preliminary thoughts around that, Josh and Natasha?
My first thought is language, not just language as in language, varying languages. I think just the understanding of concepts, I think is sometimes when we talk about being a part of our research or being involved in research, a lot of people say, well, I don't even have the education to be a part of that research. And people need to really, really, truly understand that their lived experience is such a key part of the research that we do here, even at ASC. Just understanding your story, understanding barriers that have you've experienced helps us to then do the research that we need to do to break down those barriers. So I'm not sure if that's what she means, but in my thought is that to have research being conducted again in communities in settings that aren't academic and sometimes very sort of straight line. Sometimes we need to break down those barriers for folks and just access to research in a different way. So that would be my initial thoughts without knowing a lot more.
Thank you. Next question is, please comment on the influence/risk of interpersonal violence caused brain injuries on the demographic differences in the prevalence of Alzheimer's that we see between sexes and genders.
I could try to address that. So brain injury is a risk factor for developing dementia later in life. And for a long time, we often attribute that more to be more of a male issue from violence or work in the military. There's been some research in that area, sports. So often thought it was a male challenge, but there's been growing recognition that it also is a female challenge. So there's a difference between the sexes, and that interpersonal violence or intimate partner violence as well can have an influence on brain injuries and lead to dementia in females, but also concussions from women playing sports. Females playing sports can also raise their risks. So there is I think a more growing understanding of the sex differences when it comes to head injury and dementia outcomes. So hopefully that addresses the comment.
Thank you. Next question is there any research you can comment on in the report about mixed dementia as a caregiver to a racialized family member newly having been given this diagnosis? I'm curious to know if the report or another resource may be helpful to myself or others on the call to know about.
So when we, like as humans, we often like to find categories and put people in boxes. So you either have Alzheimer's disease or you have vascular dementia or you Lewy body dementia. But when we look at older adults, especially after the age of 75, having one of those boxes doesn't really work because people have, they'll have all sorts of different pathologies within their brain. So that's where this idea of mixed dementia comes from. So someone might have the pathology related to Alzheimer's disease, the plaques and tangles, but then also have some issues with their vascular system within their brain. So I'm not sure how that relates exactly to racial differences. I'm not sure if there's been a lot of research to kind of look at differences. This idea of mixed dementia is relatively new because we used to like to just tick those boxes and have kind of these neat categories. But when you get older, I think it's more likely to have that you're actually having issues across different aspects of your brain. So we're growing that understanding. I think we need to do more work to try to better understand that and how we might be able to work to address that through different treatments or approaches.
You're right in that what we're learning a lot more about are sort of the pathobiology, right? So if we were able to look very closely in the brain at some of the things that are, or some of the, causes of dementia, for the different kinds of dementia, we often are learning more and more that Alzheimer's disease is often very mixed disease in and of itself. There's many things that have classically been associated with other causes or have been classically been associated with causing other dementias associated with Alzheimer's disease. So this is definitely very much a rapidly advancing field. We're limited by the fact in terms of how we can study the brain, right? Because the brain isn't something you can study quite easily. It's often done by proxy using various types of imaging and that kind of thing. So, but that's advancing. Thank you for that comment. Next, there is a lot of dementia risk reduction information and education, but people are not taking action or enough action. What new approaches or methods do you think should be taken to educate and incite people to take action to reduce their own risks of dementia?
It's a great question.
Mhm.
I think it's been known for a long time that it's not enough to simply just educate people about health risks. We need to figure out ways, or I don't have the solution, but we do certainly need new approaches and methods to try to make the behavior changes across the population. Not easy to do this, I think. So I think we need to determine how we can have policies that might shift behavior, how we can design environments to maybe encourage physical activity. Maybe we can influence healthy eating for different strategies. There's no one easy answer for this, but I think we start with awareness and talking about it, and then we work to try to design solutions to address this wide risk across the population.
Thank you. Next up is INBOW raises an important issue. Many researchers are trying to tap into diverse communities. For example, the Schlegel UW Research Institute, University of Waterloo Research Institute is leading very similar research. How can researchers begin to collaborate in ways that doesn't duplicate or overburden people with lived experience as co-designers of research? Very fascinating comment.
I personally don't have a quick answer for that. I think that's something we're all trying to figure out and work on. I think we know that we need to involve people of different communities within research work itself. We can't just go in, pull data out and leave and go run analyses and not share anything back or not have people involved. So this idea of co-designers of research is important. And also this idea of overburdening populations is also something that we need to consider. So how can we best organize ourselves and coordinate across the country to try to best address these challenges in different populations or different pockets within the country as well. I think it's something that some coordination, and good collaboration can really help with that.
Yeah, and I think that also sort of a real meaningful planning for what it is we are doing research on. So again, just like Josh has said, like before we go out there and ask for co-design, are we going out there to talk to the researchers about what we are doing? So, for instance, is ASC contacting University of Waterloo to say, hey, what is it that you guys have for the plan for the next year so that we can make sure that if you need our help or if we need your help, or if we can do some co-design, where can we work together? I think taking a step back in our planning and really doing some like real meaningful work before we go out there might also help break down those walls, those silos that we always talk about.
And I can comment, the good news is, although Canada is very large, the dementia community is quite small and very well connected. And I'm pleased to see people like INBOW on the call and people like Viviane Poupon, who are leading other national research groups that have a focus on dementia in different ways. And you have my assurance from the Alzheimer Society of Canada that you will see more and more collaboration, less duplication, and greater impact from the research dollars that we do have access to. We're beholden to do our best to Canadians, to taxpayers, to everyone here to work together in a way that has the greatest impact. And I think that the dementia research community across Canada is incredibly talented. We're so fortunate to have a lot of the researchers, leading minds really across the world here in Canada. So I greatly appreciate your question, Jane. Okay. So I don't see any other questions at the moment. So I may thank our panelists. We're approaching the end of our discussion here. Thank you, Josh. Thank you, Natasha, for a really great series of talks. I really appreciate everything that you guys have done to get us here. I would also like to thank our partners on this Brain Canada, and thank you all for attending this talk. The team will follow up in the next couple of days with those who've asked questions. I don't think we have a situation here where there are any unanswered questions. However, if anything does come up, please don't hesitate to reach out to us. And join us next time on March 20th, when we'll be talking about women in dementia. And more info on that can be found on our website, alzheimer.ca/March Talk. And just so you know, the recording of this session will be posted to the Alzheimer Society of Canada's YouTube channel in the coming days. And if you have any feedback, please don't hesitate to reach out to us. Thank you once again for joining, and we wish you a wonderful day.
Thank you.